Is different, and that will vary with what age that kid is. So I don't know if y'all have noticed, how many of y'all have worked in cases, even if it's tonsils and adenoids, with young kids? So have you noticed, you don't just get a flip of the coin for who's your anesthesia person. There's someone who knows young kids, who does the young kid cases all the time, right? So anesthesia is one of those areas where you notice, okay, kids are different, because not just anybody shows up to help run anesthesia with young patients. It's somebody who deals with kids and knows kids, and they adjust depending on where that kid is at as far as age and their ability. So it says in the book, you can just highlight that whole paragraph for metabolism. Infants have a higher basic metabolic rate and metabolism than adults. The rate is greatest at 18 months. So, and that makes sense. So at 18 months, what is what's a baby up to at 18 months? They are driving you nuts at 18 months because they're old enough, they can't just roll over, they can scoot around and they can get into stuff and they can make a mess, and when do they stop?
Never.
That short time when they take a nap, and then they're right back at it, right? They're Energizer bunnies at that age. Because they have the fastest metabolism they will have in their entire lives at 18 months. Things are happening fast for them. It says, children younger than 2 have an increased percentage of total body weight and extracellular body fluid. Immature liver function, that's important. An immature blood-brain barrier, altered pharmacologic response, slower hepatic clearance, decreased hepatic enzyme function, and decreased protein binding, which results in an increased sensitivity to sedatives, opioids, and hypnotics. So anesthesia drugs that we typically use hit these young kids hard. And so anesthesia has got to be aware of that and say, okay, depending on the age of the kid, how do I have to dial back the drugs that we're using? But you still got to use enough that you anesthetize the patient so they're asleep and not feeling anything. So it's a little more tricky for that particular age group, and it varies. Are they 12 months old? Are they 18 months old? Are they 24 months old? What their function is like is going to be different at all those different age points. It also talks about fluid management, and you can highlight the first 3 lines there. Renal function at birth is immature, which makes sense. So with young babies, do they pee a lot? They pee all the time. If they drink, they pee, and they don't wait and separate the two. You can be feeding the baby a bottle, pop the bottle in, and pee starts coming out the other end, and it's like, well, they urinate a lot. Why do they urinate all the time? Because their liver function is not mature, and their renal function is not mature. And what is the basic job of the kidneys for us? Basically a blood filter, right? So it filters out the stuff that we don't need, and we as adults don't pee a lot. We pee a couple of times a day, maybe 3 or 4 times a day, but not all the time. So what does that mean about our kidneys versus young kids who are peeing all the time? They're not very efficient at separating out the stuff they're trying to filter. They filter it with a lot of water, and so they need to drink a lot. So their kidney function being immature basically means they're not good at holding on to their fluids. They lose a lot of fluid as the kidneys are doing what the kidneys are supposed to do. So they're just not real efficient at cleaning the blood, and so they lose a lot of fluid in that process. So for us for anesthesia, what does that mean about them managing young kids? Keep that IV going, or manage the IV, watch the input, the output, what's going on, and maintain the right levels of fluids for that patient. And then in table 26.1, it talks about some of the developmental stages. So how many of y'all have kids? Okay, so you have been through this and you are well aware of this. For the rest of you, if you've babysat, when I was in high school, that was one of my main jobs, was babysitter. And was I just in love with little kid? No, but it was something I could do. I could make money. People trusted me. I did pretty well with the kids. And shoot, yeah, I'll go babysit. You have cable, right? So the kids go to bed. I can sit and watch TV. And usually that's when people want a babysitter. In the evening, they go out and have dinner and watch a movie, whatever. So it was something that was easy for me. But so what's the developmentally based fear of infants to 1 year in that chart? Separation. So I don't know if y'all have noticed, but babies that are under a year old, they don't play peekaboo so well until they get about a year old. Then it's a game. But at first, if mom's like around the corner and going, hey, peekaboo, and they disappear around the corner, the kid starts crying. They don't understand, she's around the corner, you just can't see her. No, mom disappeared, she's gone. I gotta worry. So they don't get that yet. They don't put that together. So separation is a big thing. Can you pass them off to someone else and they be okay? Early, you can, because they haven't kind of glommed onto, this is mom, this is dad. I'm cool with them. Anyone else? Not so much. So separation initially is they want to be near someone because that represents safety for them. As they get a little older, as toddlers, the separation changes a little bit. They're identifying faces and they want to be around those people they're comfortable with, right? So if grandma comes over and spends a lot of time with that kid, grandma's one of the safe faces. If I see that kid at church and say, hey, can I hold him a minute? And I take him, I better scoot next to mom. Because otherwise, hey, this big dude with all the hair, no, that's not mom, that's not dad. I don't know who this is. Until they get real familiar with you. So that separation is big. And I remember Dr. Early, one of the anesthesia doctors that worked for years alongside me and Elda, you wouldn't know she was really good with kids until there are kid patients coming up and suddenly she starts shining. Because she goes from the adult in the room to their buddy, and she'll go into the room with mom and dad, and it's a 2-year-old who's really got stranger anxiety. And so she's like, hey, so as we're talking, I'm gonna slowly ease up to you guys, and at some point, I'm gonna take the baby from you and maintain touch with you, mom. Okay. So that's gonna be part of our discussion while we're talking. And so she eases the baby over, baby's like, wait, no, mom's right here, I'm touching mom's arm, we're good. And then during the conversation, she slowly scoots away and mom and dad are talking to her and everything is fine, and the baby's like, oh, okay, no, we're good. And by the time she walks down the hallway, the nurse is like, do you want to put him in the little stroller pram thing? No, she's with me. And the baby's like, no, we're cool. I know this person, I trust them, and we're good. And she just had a way with kids, and she would walk them into surgery and sit down in her chair, baby's in her lap. And she's talking to them, and she's talking about what's going on in the room, and the kid's like, oh, okay, well, yeah, you just stay right here with me. And then pretty soon it's like she's got this mask, and she goes, hey, you like grape smell? And she rubs some of that grape smell in the mask, and look, check that out. Do you want to hold it? And the baby's like, yeah. And they're holding it to their face, and she begins to crank the juice on, and pretty soon the kid's asleep, and she goes right back to business. Put the baby on the table, put the straps on, we do this, we do that, we go on, and here we are. And so it was something that's, when you see somebody who's really good with that, it's an art form. It's like, wow, you don't have any kids, but you really should have had kids because you're really good with them. But watching them kind of get around that, and that's because she really understood that stranger anxiety, that separation fear, and she knew how to work through that without alarming the kids. Have y'all seen any anesthesia who's not real good with kids, who had to work with kids?
Yes.
And the the kid's screaming and crying and fussing and they're not happy. And when they wake up, guess what? I remember I'm not happy, I don't like this. And they're throwing a fit and they're fighting and they're doing everything else they can. With hers, when they would wake up in recovery, she's there, she picks them up. Oh no, I'm with this lady again, we're good. And they whimper a little bit because their throat hurts because they just got their tonsils out, but they're fine. And then mom comes in, she hands them off to mom and says, here, just watch the IV and do this and do that. And it was a pretty smooth process. So notice the developmental based fears is what I'm interested in this table. But after toddlerhood, early childhood, and preschool, what are they worried about? A little bit about separation, but there's a new fear that comes on, and that's bodily mutilation. Because they hear, you're gonna have surgery. Are you gonna cut off my arms? What are you gonna do? And they have some crazy ideas. They've never experienced this. They don't know. They just know they're gonna do something to me, and I gotta be away from my parents, and this is a little worrisome and odd, and what are we doing here? So they're worried about looking different. We've all been through middle school, right? In middle school, who gets picked on?
Everybody look different.
Whoever's different.
Yeah.
In what way? Any way we can find.
Everybody.
Because we all turn into chickens. And if y'all have ever dealt with chickens, what chicken gets picked on? The one that looks different.
Mm-hmm.
If you got a sore, the others will pick you to death. No mercy, you're different. We're gonna be yanking feathers out of you until you've got nothing left. And it's like, man, you guys are brutal. It's like Lord of the Flies down here. Yeah, they're that way. Middle school, they're kind of that way. Do the kids realize that that's kind of the way things work in middle school? Did y'all know? Yeah, hey mom, I've gotta have these shoes or else I stick out. I don't know why Nikes were cool shoes, but like I need those. So kids are always looking, what's your haircut need to look like? What brand of shirt do you need to be wearing? And they're kind of keenly aware of that in that middle school phase. To some lesser extent, physically they're aware of that. And if they're going in for surgery, wait, are you gonna make me look different? Is there gonna be a big scar on my face that everybody's gonna go, hey, look, this dork's got a big scar. They're afraid of that. So body mutilation is something that they're keenly aware of and are worried about. And then middle school, middle childhood, so early or later elementary and maybe into middle school, is the unknown. So what's gonna happen? Am I gonna die, or what's gonna go on? Am I gonna be different afterwards? What are you gonna change with me when we have this surgery? And then once they get into adolescence and puberty, it's altered body. So am I gonna look different is still an issue. And then, am I gonna die? That's about the age they start realizing we don't last forever. Death is a possibility. I've kind of seen that with other people now in life, and I don't want to be the next in line for that. So that starts becoming an issue for them. Does it say for every age group that that's the most logical thing they should worry about? No. But at that age of development, that's what they do worry about. So it's good to know as a surgical tech, what are my patients worried about at different ages, because we can help with that. So with adults, what are some of the things that we typically do in surgery with the patient in mind, even though we're not over there talking to the patient, we're doing our job.
Being quiet, not making a bunch of ruckus.
One of the big things is be quiet. So if, as the nurse brings the patient in and introduces everybody or points them out, and she says, this is Jason, he's a surgical tech student, it's a good thing to turn around and say, good morning, I'm just getting all of the doctor's stuff together. And that way they know, okay, so I don't have to worry about that guy over there. I know what he's doing. He's getting the doctor's stuff together. But it's kind of nice to be able to explain that. So in the summer when we were looking at skills and like move over from the gurney to the bed, If nobody says anything and they just jerk you over to the bed, is that a little unsettling? More than a little, and you knew what was gonna happen. So with the patient, they have no idea. A lot of them have not been to surgery before. It's all brand new. And so what you see a lot of going on with nurses is they're communicators, they're talkers, right? They tell the patient everything they're gonna do before they do it. Why is that? That's how you keep the patient calm and keep them where they understand a little bit. It's like, just tell me what you're gonna do and don't surprise me, and I'll let you do whatever you gotta do. So nurses are working that job pretty well all the time. They're always leading by example in that aspect, because that's how you keep your patient calm. So with adolescent patients or pediatric patients, same thing, but it changes a little bit, what they're afraid of or things like that. And so rather than introduce everybody in the room, they may turn it more into, no, look at me, I'm talking to you, and we're good. I'm the one who's taking care of you. Those are just other people in the room, but I'm the one who's gonna help you take a nap. When you wake up, you're gonna see me. I'm the one you wanna talk to, and so they kind of change the rules a little bit depending on what those developmental fears are that the patient may have. Okay, so how many of y'all have been to Driscoll? It's a different communication with the patient, right? But those nurses are fantastic at what they do. All the ones that I've met from Driscoll are really good at what they do. And you'll watch them and it's like, yeah, you should be doing exactly what you're doing. This is your job, this is your calling. Because look how you do with the kids. So they're good at it. They enjoy what they're doing and they know they're good at it, and they kind of flourish in that specialty. Some of us go to Driscoll. Who did I see laying on the table every time I had some new person come in the room? I'm thinking, that's my kid, and that's rough. I'm also thinking it's 105 degrees in here and I'm not comfortable in all these layers working in the heat. I don't like working in the hot room. So some of you may go to Driscoll and realize the first morning, it's not my cup of tea. It's not for everybody. That's why the whole city's not fighting to go work at Driscoll. The people that are there are happy, but it's not something that just everybody wants to go do. Some people, it's like, no, it doesn't work very well for me. Okay, if you'll turn over to the surgical interventions, they go a little bit over some of the idea of vascular access. We'll cover that in CV or peripheral vascular. But I do want to start with the minimally invasive surgery, and they have laparoscopic pyloromyotomy for pyloric stenosis. That's a mouthful. So pyloric stenosis, what's the pylorus?
Anchors? The end of the stomach?
Yep. So that's basically, you got your esophagus, you got your stomach, the part of the stomach that filters down to become the small intestine, that's your pylorus. Some babies are born where there is a sphincter muscle right at the base of the esophagus, so when you swallow food, it relaxes, lets the food go through, and then you tighten it up because babies are not usually standing up. They can't stand yet. So where do they go after they eat? Lay them down. They may roll to one side or the other, but they're laying down, and the food's not supposed to back up. Although with babies, it frequently backs up, but it's not designed to back up. So there is a sphincter muscle at the top of the cardiac sphincter that stops the food, or designed to stop the food from backflow. In the stomach, we also have a sphincter muscle down here designed to stop the food from leaking immediately out of the stomach, because the stomach is, what's the stomach do with the food that it gets? What do we add to it?
Yes.
We add stomach acid and we mix. So the stomach can kind of squish back and forth, and it mixes the food that you ate with stomach acid to kind of blend it together so that as it's moving through the rest of the GI tract, it's dissolving and it's being absorbed and you're digesting your food. So the pylorus is primarily a sphincter area to hold it, and then as it becomes mixed, it slightly lets loose and lets a little trickle of food come through. So you can slowly and under controlled circumstances, you can digest that food. If it was just to completely let loose, the food would all dump through, and then an hour later, they've got diarrhea and everything shoots out and they're hungry again because they didn't get to digest the food very well. So the pylorus, it's important. It needs to regulate the passage of food coming through. With most young kids, that's exactly what happens. With some young kids, they have this built up hypertrophy, and there's a mass of muscle at the bottom of the stomach, and it's like, whoa, kid's the Incredible Hulk down here, what's going on? Well, it's overdeveloped, and if there's too much muscle there, it's just like at the gym. The guys that get really big, how flexible are they?
Terribly.
Not flexible. That's their weakness. And why is that? Because there's not room to be flexible. There's too much muscle mass in the way. With my son, he's like, "You're talking nonsense, Dad. There's no such thing as too much muscle mass." Yeah, there is. So with those big guys, there's too much muscle mass in the way. They're not flexible. With the pylorus, you're not trying to flex with it, but if the pylorus wants to relax and there's a lot of mass there, even when it's relaxed, the food can't go through and they can't digest their food. So the mom's feeding the baby's throwing up, they can't pass the food down. They do some testing and discover, okay, the pylorus is overdeveloped. So we're gonna do laparoscopic pyloromyotomy on that pyloric muscle. In mine, it's 1007.
Oh, what about
1067. Okay, so in that probably 1, 2, 3, 4, the first 4 or 5 lines. So pyloric stenosis, it defines it, it's the most common cause of gastric outlet obstruction in children, and it's the most common condition requiring surgery in a newborn. Signs and symptoms of high GI tract obstruction appear when the infant is 2 to 6 weeks old. First sign is bile-free projectile vomiting. So what's projectile vomiting? That's not just it spits up and runs down the side of the mouth, it shoots out like a hose. So if it's projectile vomiting, number one, something is really wrong in the body. It's not just spitting up the excess food, it's getting rid of it. And so projectile vomiting means something different than just the baby spit up after they ate, because spitting up after you eat, you got a little overfull, the excess fell out, it's not a big deal, that's just part of a baby learning to eat. But with pyloric stenosis, the pylorus is overdeveloped and the food comes down, fills the stomach, and the stomach tries to get rid of it and it won't go down. So the stomach tightens up and everything shoots out like a water hose out the top end. And what's interesting is what makes that projectile vomiting distinct? What does it not have? Bile. Well, the bile plugs in right down here because you've got your liver and you've got your gallbladder, and it plugs in below the pylorus. So if the pylorus is the plug and you can't get past that, then even when you projectile vomit, that stuff's further down. It's not coming up in that. So when a baby eats, what color is the vomit? It's a white or an off-white, looks like milk, or looks like formula, whichever. So it's a whitish color. What color is bile? It's that greenish yellow nasty stuff. Anyone ever vomit bile? Nasty. It's got a taste to it, it's bitter, and you know when it comes up. So with the baby, they're spitting up food. There's no bile in it. And that's an indicator that the doctor, when they see that, will go, there's no bile in that. They're not throwing up because of something further down. This is probably the pylorus. So what do they do to go in and fix that? They have figure 26.3 and 26.4 showing laparoscopically what they're doing. Surgically, it's very simple. They're gonna go in laparoscopic, just like with the lap chole, and they're gonna be looking at the base of the stomach at that pylorus, and you can see in 26.3, what is that tool coming down from above right in the middle of the picture? Can you tell that's an insulated Bovie tip if I say it's what it is? So it's a flat piece coming down, and you can tell right as it enters or as it touches the tissue, it's lost the insulation. So just the tip is where they Bovie with it. But what they're doing is they're using a Bovie tip right along the outer edge and cutting through the muscle fibers all the way down until they get to the inner layer. Once they Bovie past all the muscle fiber, then you'll notice, oh, there's smooth tissue there. That's not muscle anymore. And so that's basically what they're gonna do, is they're gonna open up the muscle along the entire length of the pylorus and cut down through it. So you've cut the pylorus loose. If you cut a muscle loose in the body, will it reattach itself? It will over time. And what they've found is if you take an overdeveloped muscle and cut it in half, then when it reattaches, it's most likely going to reattach in a normal way, not that overdeveloped hypertrophic way. So you can cut all the way through the pylorus. When that kid eats in a few hours, are they going to be able to regulate, or is the food going to push on through?
Push on through it first.
Food's going on through because your pylorus is disconnected. You just stopped it from doing what it's supposed to do. But on the upside is, in the next few weeks, it will heal and go back to normal rather than being the Incredible Hulk pylorus. It's going to reform and heal as a normal pylorus, and it goes back to normal function. So as far as surgeries go, it's pretty simple. You set up like a lap chole in miniature, because this is a newborn. But the instruments that you need a Bovie, laparoscopic Bovie, that's an insulated except for the very tip, and they just take it down there and just kind of go back and forth and cut all the way through the layers of muscle until they're through that. If you cut into the GI tract, you need to sew that up. But if you're careful and intentional and slow in how you work through, you see that last layer and say, okay, stop cutting, that's not muscle. And you leave it alone. You strictly cut through the pyloric sphincter, and basically if the bleeding has stopped, they separate it and look at it and make sure they've separated all the muscle and put the kid back together, do the normal closures of the belly wall, and that's that for that surgery. Evacuate the gas and you're good to go. So the pyloric sphincter, they're basically just cutting through that sphincter muscle, that outer pylorus, and let it heal on its own. And it will put itself back together normally rather than overbuilt. So for that one, that's pretty much it. It does say under procedural considerations, the position, the patient is positioned transverse, supine, but at a right angled. So would it be left side up or right side up if they're working on the pylorus, which is basically under the liver? So they're gonna be right side up. Because if you think about the stomach comes down and angles over to the right under the liver and the gallbladder. So if you lay the patient on that left side with the right side up, it pushes everything out of the way and allows you to see what you're doing. So if it's a newborn or for pretty much any patient, we want to minimize the trauma we do to the patient, right? So if you can use positioning to slosh everything out of the way and see your field of view, it's a much easier way to do it. And so you can see they're operating, you don't see a lot of lap sponges, you don't see a lot of fan retractors having to push things out of the way. They just let gravity push it out of the way. They can see what they're doing. They bovie through the muscle on the pylorus, separate it out so they can visualize it, make sure it's not bleeding, and that's what they do. So that surgery is pretty simple as far as what they're doing. It does say in step 5 of the operative procedure, when they finish with this, anesthesia will inject air into the stomach through the mouth to inflate the stomach. What are they checking for? Make sure we didn't poke a hole in the deep layer of the pylorus. If we did, you can't inflate the stomach, the pylorus will bubble and the stomach won't inflate. So it's an easy visual way for them to check. And they can go in and clamp at the base of the pylorus and say, now inflate the belly. And they can use, they can push some air into the belly, fill it up. They can visually see it's filled up. Is it leaking? Is it bubbling? Nope. Then okay, let the air back out. We can go home and we're safe. Because if you have a hole in the pylorus and you wake the patient up that way, they're going to eat, and it's going to leak through the wall of the pylorus into the belly, and we're going to have problems. So checking with air to be sure that the pylorus is still intact and airtight is a good safe thing to do to make sure it goes well. The next one on the next page is endoscopic correction of pectus excavatum, aka the Nuss procedure. So pectus excavatum is funnel chest. It's where the ribs curve inward. The sternum is still there, but the sternum is pushed way back towards towards the spine of the patient. What would that do to the patient other than make them look different? What will it limit? Yeah, your breathing is going to be limited. So patients who have a severe pectus excavatum, the sternum is actually back pretty close to the heart and the major vessels, and you may have 40–50% less air capacity because your chest has caved in, basically, is formed that way. So what they figured out, and there's a good illustration of a kid with this condition before and after surgery, figure 26.6. And that's kind of what it would look like in a typical developing patient. And at what age do you think this would become an issue of, hey mom, we gotta fix this? At what age group do you start dressing out in PE? Middle school. But luckily middle school kids are very tolerant of each other, right?
Yeah.
No, they're not. They're piranhas. So at middle school, as you're approaching middle school and the kid knows, hey, I'm gonna be having to change clothes in the locker room with a bunch of other classmates, this is not gonna work, because I don't look the same as everybody else. So that typically is when they go get this issue fixed. Is the kid on the right, is he gonna be unbothered in the dressing room? Probably not, but at least he's closer to normal than he was previously. So the pectus excavatum, what they do is they go in laparoscopically, and they have a big curved bar. They can go between the ribs, push it through, and it comes out between the ribs on the other side, And then under force, they're gonna invert that bar and then suture it to the ribs on either side, and that bar is now shoving the center part of the chest back forward where it's supposed to be. I'm assuming this is probably a little bit uncomfortable for the patient initially. But in middle school, are these kids still growing? Yes. It's a good time to catch it if you're gonna fix it and have the body reform correctly, is before you stop growing. So when they're younger, the doctors will recommend, hey, it's not bothering them, let them develop. Let the kid develop normally as much as they can. And about middle school, when they're concerned about it and they drive mom back to the doctor and say, go get this fixed. I don't know what this is wrong with me, but I don't want to look different. So they can fix them by putting in this bar that they flip over. So it's called pectus excavatum. What's the other name for that procedure? The Nuss procedure. So Dr. Nuss invented this evidently. And so this bar that they put in, they flip it over, and you can see how it guides the front of the chest into the correct position to allow it to heal in a much more normal fashion. So the kid in figure 26.6, is he gonna win any bodybuilding championship trophies? Probably not, because they didn't get his chest back to 100% normal, what you would expect. But his breathing is gonna be a lot freer, and he's going to be able to develop. Aside from that, this is not a kid at the age of being able to build a lot of muscle bulk yet anyway. So when he does build muscle bulk, what's gonna be interesting is he's gonna have a dent in the middle of the chest. And when muscle builds on either side, it's actually gonna look more impressive for this kid, because he's got a dent made in the middle that makes it look like his chest is sticking out. How do I know that? Because my son had some of this, not to the point they had to do surgery, but they tried to force him not to get in the Marine Corps, because it was like, you have 25% less air capacity than everybody else, the Marine Corps will kill you. And he's like, then let me die in the Marine Corps, get out of my way, and I will go show you I can do this. I was like, I'm proud of you, but I'm also worrying about you, because you might die in the training. He's like, I'm not gonna die in the training, get out of my way and I'll show you. Turns out he's hard-headed and he can do it, but when he built muscle, when his shirt comes off, it's like, holy crap, dude, how did you do that? That's not Madden muscle, that's something else. And he's got a dent, or the way his chest is constructed, the muscle that's on top looks extra impressive because it's curved to where it sticks out, and it's pretty obvious. And we've been in HEB where people come around a corner and it's like, holy crap, that dude's ripped as fuck. I'm like, yeah, thank you. It's a deformity that he's working his way through, but yeah, it kind of makes him look impressive. So.
I have a question.
Yeah.
So on the first picture, it shows how the ribs are curved.
That's how they were formed before the surgery, yes.
So how is it that they're gonna turn, like picture B, do they shape them down or?
So we put that bar in, and when you flip it over, you shove it forward and anchor it in place on the ends. And it is forcing the center part of the chest, because when you do CPR, the chest is flexible. It has some flexibility built in there. So we're just taking that flexibility and shoving it forward and holding it in place. So
going for that flexibility.
if we did that to a 30-year-old, it wouldn't work as well, because we've already finished growing. But those kids are still growing. And so if you shove it into the right place and leave it there for 6 months, it will regrow the shapes of the bones on the anterior part of the chest, more to what we're looking for. And then at some point, they will pull that bar back out, and then you've got the chest shape that you've got. But it's a lot closer to normal than before. And medically, what we're looking at is, we don't care what's he gonna look like bodybuilding. What we care about is, let's fill out that space so that they can use their lungs and they can breathe, because there may be a point where the bad dog in the neighborhood comes out and you've gotta make a sprint across the neighborhood to get away from him. How are you gonna do that if your lungs are kinda collapsed?
So that bar doesn't stay in place forever, like, what would it stay?
Right, that bar is long-term, but it's not permanent.
Okay.
So 6 months or so, they pull that back out. But 6 months is enough time to allow the new shape to take place, and the bones will reshape themselves much closer to the normal. So the patient there is after they remove the bar. Probably before they removed the bar, he was completely up in normal position. They take the bar out, and it's like, okay, so it looks like it regressed a little bit, but your body has grown to this point, and that's what you've got. But medically, what we're looking for is try and get them as close to 100% of air capacity as we can. Okay. And then the slideshow for this one is not real interesting. It's just a list of what are the surgeries that we're gonna go over. So we'll just kind of flip through the book and go through them. In this one, I didn't have a lot of good illustrations to go with what's in the book, but we can cover the concepts and get them through there pretty well. And then the book has illustrations that actually point out pretty well what we're trying to cover. So it's gonna start at the top of the GI tract and we'll work our way through. So esophagus or esophageal atresia. In esophageal atresia, the esophagus does not connect the mouth to the stomach. It starts at the mouth and goes partway down and then ends in a blind pouch. And at the stomach, it may come partway up, but end in a blind pouch. So the stomach and the mouth do not connect. Would that be a problem for the patient? Life is not compatible with life. You find this pretty quickly after birth, and this is a newborn, brand new kid surgery that we do because life won't go on if you can't get food down the hatch. So it does say in the book under repair of esophageal atresia, second sentence, it says several types are recognized, with the most common being an upper segment of esophagus ending in a blind pouch and a lower segment of esophagus communicating by a fistula to the trachea. So the trachea is a tube that connects what to what? It connects the mouth to the lungs. So on the top half, the kid can swallow food and it ends in a pouch. There's nowhere for it to go. It will come back up. In the bottom, the stomach has what looks like an esophagus coming up, but it stops and just cuts off. Bless you. But it has a fistula connecting it to the airway. Anything bad could happen with that? If stomach juice comes back up, it's gonna be shunted right into the lungs. So we can't have that either. So we've gotta, number one, we've gotta repair the connection of the esophagus, but also we've gotta get rid of that other connection because that's not compatible with life either. And they show that illustration on figure 26.11. This is you can see the proximal end, the little pink tube on the left of the photo. That's from the mouth coming down. The esophagus just plays out and stops. And then further down in the airway, one of those connections there in blue is to the stomach. So they've got to disconnect the stomach from that side and figure out how do we reconnect the esophagus and put it back together. So initially, is this baby gonna grow a lot? Because this is a newborn. There's a lot of growth to take place still. So initially, what's the first way you could get it where the baby could have access to food? A feeding tube. You put a feeding tube through the belly wall into the stomach and you feed the baby. If the mom's pumping, can you still inject that into the belly of the baby? Yeah. So formula breast milk, is one better than the other? If you ask the formula company, no, they're the same. They're not the same. Humans were developed for mom to feed the baby, and is there anything like antibiotics related to breast milk? Yeah, mom, all the illnesses you've had, you will pass those immunities on to the baby through breast milk. It's good stuff. There's a reason naturally that happens. So breastfeeding is the ideal way to feed an infant. If you can't feed the baby, put them to the breast and have them eat because the esophagus is not connected, you can pump and you can inject that into the feeding tube. Baby still gets the nutrition, they still get the things that they need out of that. Is there anything else the baby gets out of breastfeeding that's important to the development of the baby and the well-being of the baby? Skin to skin. That's more important than a lot of people used to realize for that baby. When they're developing, one of the things that they need is skin to skin contact. Can dad do that too? Yeah, get your shirt off and hold that baby. Put a blanket over both of you or whatever. But those newborns, they thrive with skin against skin. Why? I don't know. That's just the way they're made. But as far as a baby born with esophageal atresia, and the mom's like, well, crap, I can't breastfeed. You can. It's just gonna look different. But you can get the skin to skin still. You can put the breast milk through the tube into the feeding tube and still deliver it to where it needs to go for the baby. And so they can still develop in a healthy way. Why don't we reconnect the esophagus with the newborn? Number one, because the upper and lower esophagus don't come right there and just have a line in between them where they almost connect. Usually there's a couple inches of space. And if you just chop the end off of both tubes and pull it back together, is that gonna be okay?
Nope.
They don't fit. So you've gotta let the baby develop and grow. At about a year, the kidneys are working better, the liver is working better, anesthesia's happier having to do surgery on that baby because they can handle the anesthesia drugs a little better. And we'll go back in and put a permanent connection between the upper esophagus and the lower esophagus. Anyone know where can you get a tube to connect those? Ideally, you get it from the patient.
Colon?
They'll take the transverse colon, and one edge of the transverse colon is in this corner anyway, with blood supply. We can disconnect it, hook the rest of the colon back together, they can live with 3/4 of a colon. And we can take that part of the colon, turn it the same direction where the food normally flows through, right to left on the patient, flip it so that it's flowing up to down, but we can reconnect the top and the bottom of the esophagus using the colon, and they can go about a normal life as that heals. It will grow as they grow, it's part of them. And so it grows at about the same rate as the rest of the body, and so they can do that. So the esophageal atresia, initially, we're gonna go through and disconnect the lungs from the stomach, stop that connection, and then we've got to put a feeding tube in. So initially, we're putting a feeding tube in, it's kind of a stopgap surgery, and let the child develop because we can give them good nutrition now. And at about a year old, if the patient is otherwise healthy, any of you guys know any kids who have birth defects? Whether they're in your family or not, just any that you've been around? Did they have only one birth defect or did they have multiple problems? The vast majority, unfortunately, have a whole variety of issues going on. So when one thing happens, the doctor starts looking. It's like, uh-oh, what else is going on here? Because usually, if they've got one, they've got 4 or 5. So at a year old, if the patient is healthy enough to put up with the surgery, they will go and take the transverse colon and turn that into the esophagus so that they can reconnect everything and the baby can eat normally again after that to go forward. But it all depends on what other birth defects might they have. And it's not like with birth defects, it's like, oh, you've got combo platter number 3, you've got esophageal atresia, you've got this, you've got that, you've got this other. That's a common combination. With birth defects, you never know. But they've got to look and trace them down and figure out what is not working correctly so that we can fix that. But just know with birth defects, when they've got one, they probably have others that we've got to figure out what's going on so that we can address all the issues. Okay, and the rest is just a listing of the other surgeries that we're going to look at. So, reduction of intussusception. So, anyone remember what intussusception is from the GI chapter? AKA invagination, AKA telescoping. So, when the bowel is supposed to be one continuous tube, if part of it crimps down a little smaller and falls within the larger bowel next door, it's telescoping. And if you've ever seen a telescope that collapses down, one tube fits in the next tube, that fits in the next tube, fits in the next tube, they all become a convenient package. You stretch it all back out and it's your telescope again. So telescoping is a common description for that, but intussusception in the belly is not an uncommon thing for newborns. It's after necrotizing enterocolitis. So there are more surgeries in this chapter than I want to cover. Y'all probably know by now, if I'm going to cover it, you're either going to see it locally or it's on the AST test. So the ones that are on that CST exam, I want to make sure we cover, and intussusception is the next one in the list that is on that test and is relatively common. So intussusception says is the telescopic invagination of a portion of intestine into the adjacent part with mechanical or vascular impairment. So if there's mechanical impairment, what does that mean? This is part of the gut. If it's mechanical impairment, that means the food can't pass through, it's blocked. If there's vascular impairment, what does that mean? Part of it now has no blood supply. It's a more complicated problem because now when we pull it and stretch it all back out, there's a gray piece of intestine, that's the dead part, we need to cut that out and remove it. So if it's mechanical impairment, we need to stretch it back out and fix it so that the kid can move food through the GI tract and can process the food. If it's vascular impairment, there's a blood supply problem. We have to cut out the dead bowel and put it back together. It says the most common site for intussusception is the ileocecal junction. So where's ileocecal junction? What comes together? What joins at that junction?
Ilium cecum.
Right, which is the small intestine and the colon, right? So the end of the small intestine, beginning of the colon, what worm is hanging off there too?
Appendix.
Yeah, so the appendix hangs off right near the ileocecal junction. If you've done colonoscopy, how do you know you're at the end of your colonoscopy? You run into the ileocecal junction. So you go through into the small intestine, it's like, well, that looks different now, that's a smooth tube. Well, it's because we're through the colon into the small intestine. We can begin backing up now and check all the nooks and crannies. So the most common site is the ileocecal junction. And it also, the next thing there is important, intussusception in most children is idiopathic. What's idiopathic mean? Anybody know? Pathic is pathology, so the problem begins idio, whatever that is, And basically it means spontaneous. So it wasn't there suddenly for whatever reason, part of the gut folded inside of itself. It's like, whoa, that was weird, what's going on? We're not able to push the food through now. So a lot of times it's idiopathic, it's spontaneous. It just happens. And there may not be a disease process going along with it. So it might be something that, oh, okay, mom, this is not a birth defect. We don't have to worry about things. This is just one of those odd things that can happen with young kids. So it says it's the most common cause of surgical emergency in children younger than 2. It's relieved by reduction of the invaginated bowel during laparotomy or laparoscopy. And early diagnosis and reduction are essential to bowel viability. So if you leave it folded in on itself, the longer you leave it, the more dangerous it becomes, and the more likely it is that it will cut off the blood supply or damage the patient. So if you catch it early, what's the corrective action? Stretch it back out. And that part that's folded into the large intestine, pull it back out so that you can see it all laying there, and let go and watch it a minute. If it immediately tries to pull itself back in, pull it back out. Hold it in place for a few minutes. But it usually, if you just stretch it back into the correct position, it will stay back in the correct position. I'm not quite sure why it's okay to do that, and it won't run back in on itself, but they have tried it and figured out. If you just manually stretch it back out and put it into the correct placement, it tends to stay there. And won't run back into the problem it was. On the next page, we've got resection and pull-through for Hirschsprung disease. This is much further down. This is in the colon. And with Hirschsprung disease, it's pretty interesting. The first few lines there says Hirschsprung disease is characterized by the absence of ganglion cells in a distal portion of the bowel. Anyone remember from Bob Long's lecture on the colon? What are ganglion cells? What do they do in the colon? Or if you think about the colon, what does the colon do to get food to go on through? What's that muscle contraction called? Peristalsis. That's due to ganglion cells. They're the ones who fire the muscle off and make it peristalse. So in Hirschsprung disease, part of the distal colon, distal bowel, is lacking ganglion cells. So have y'all ever seen a doctor in the bowel, in the belly, witness that peristalsis activity? It's not constantly rippling muscle, but if you sit there and wait for 30 seconds or a minute, you will see that ripple effect go past. So that peristalsis happens. It doesn't take 20 minutes of waiting to hope you catch it. It's gonna happen every 15, 20 seconds. And so you can kind of witness it and have an idea of where there are not ganglion cells and where there are. But so what the doctor's gonna do is take frozen sections of the colon wall. They're gonna take a frozen section, maybe put a stitch with some long tails there so that they know where they got it from, and they send that into the lab, and we sit around and wait. The lab will call back in 15 or 20 minutes and say, yeah, I don't see any ganglion cells there. Okay, well, let's go upstream an inch and let's take another frozen section, send it to the lab. So they're gonna send multiple frozen section biopsy specimens of the muscle of the proximal portion of the colon to determine presence of ganglion cells. So they're sending frozen sections. What are they looking for? Ganglion cells. If they find it, okay, move distal, look again. Yes, you have it, move distal, look again. And so they look until they find, okay, there are no more ganglion cells there. Okay, that's our upper margin, we can mark that. Well, let's go lower. How far down does this go? And hopefully by the time you reach the rectum, its normal cells again, and you can cut the diseased portion out because it's not moving food through, there's no peristalsis, and they just get plugged up. So they'll go through and remove that part. Actually, what they do is they identify it early in life, and then at the last paragraph there in that section, it says, if clinical and nutritional status permits, the child is returned to the OR for a definitive repair at 1 year of age. So why would they wait till they're a year old to completely fix this? Because young kids, what's their problem with anesthesia?
Don't do it.
The liver's not functional and not able to handle drugs normally. The kidneys aren't able to handle drugs normally, and so it's safer if you wait till they're a year old and then go back and repair this in order to have the patient come through it safely. So if part of your colon is not sending the food through, you can't do peristalsis with part of it. What are they going? How do they fix this initially with this kid if they're not going to remove the diseased part of the colon yet? Because food is going to go through the colon until it gets to that blockage.
Colostomy bag?
Shunt it out to the belly wall and do a colonoscopy or colon colostomy. Yes. So they will do a colostomy bag for that young patient, and the poop comes out through the bag because the distal colon can't handle the food. It doesn't push it on through, and it creates a blockage. So until they're about a year old, they will wear a colostomy bag, and it's just part of what you deal with. They're young kids, they're not eating a steak dinner, they're drinking liquids. And so at a year, if nutritionally, if they're able to put up with removing the diseased part of the bowel and reconnecting it, they'll do that at a year. Otherwise, they're still aiming for a healthy enough patient that they can do that final stage with. The next one is repair of imperforate anus. So imperforate, the word perforate is there. So if the anus doesn't perforate, what does that mean about this baby?
Can't poop.
They don't have a butthole visible. So the colon is in there, and it ends at an anus, and the anus ends in a blind pouch, so the poop doesn't come through. Would that be a problem for a young baby? Absolutely, because that food's got to go somewhere. It works its way through the digestive tract and it's got to go somewhere. So it is going to present a problem. And actually, it doesn't end in a blind pouch. It will find neighboring areas to be able to shunt itself into. So it says in there under repair of imperforate anus, the second sentence, it says female patients or female infants commonly have low lesions, and male infants primarily exhibit intermediate or high lesions. A covered anus and anal-vulvar fistula are examples of low lesions. So with the female, it will create a fistula near the anus over to the vagina, and they poop through the vagina. Those of you who are female in this room, is that a problem?
Yeah.
That would be a problem. This doesn't go there. I know they're next door to each other, but no, don't put these germs over there. It creates a problem. With newborns, it's not a different issue. It's the same issue, is that's problematic. For males, let's see, intermediate and high lesions include a blind rectal pouch or flat bottom and posterior urethral fistula or a fistula to the bladder. Males, the poop dumps into the ureter or into the bladder. Either way, they also have a problem. That you're not supposed to have GI tract germs in the GU tract. So either way, it's a life-threatening issue that we need to fix. So they have some pretty detailed images on figure 26.20, looking at the pull through and how they handle that, but they're basically going to reestablish the anus where it belongs. And one of the technical things they're gonna have to work through, because the general idea is, well, you open the belly and you find the end of the colon, and you're gonna have to cut through the butt and push that through there. But within the buttocks and that tissue, there is a circular muscle that's pretty important to regulate, is it coming out or do we stop it from coming out? Newborns don't know yet how to regulate that anal sphincter, but they learn that pretty early on in life, right? So potty training, when they're 18 months and they're learning to be potty trained, or 24 months and they're learning that, they have mastered control of that muscle and they know how to handle that. So in order for this newborn to have a shot at doing that later in life, which would be nice to be able to control your bowel movements, as they open up where, between the buttocks, where there's supposed to be an anus, is there a midline crease or line or anything on the newborn? If you think between the vagina or the penis, depending on the infant, and the butthole, there is a little line of tissue that indicates that's the midline. These kids don't have the butthole, and that line of skin is probably not there. So the surgeon has to go in carefully, create an opening in the skin, and then they're gonna use a nerve stimulator to stimulate the muscle fibers to be able to tell, is there anal sphincter muscle there? You zap it and you see it tighten up on that side, zap this side, you see it tighten up, okay, we're within the anal sphincter. So they gotta, they're gonna carefully burrow their way through the middle of that anal sphincter that is not opened up like it's supposed to be, it's all mashed together. So they've gotta figure out, how do you separate it and leave some muscle on both sides? Does it have to be 50-50 when you burrow through there? You don't know if you're going 50-50. You need some muscle on either side, but if you leave some muscle on either side and pull that anus through there, as it develops and heals, the weak side, guess what? We'll build more muscle. And the strong side will realize we're not using all these muscle fibers, we can let some of these go. So the body will readjust and correct itself, but the doctor has got to be careful enough to get into the middle of the anal sphincter somehow to be able to do that pull through, so that anal sphincter control can develop. So they show a picture on 26.21 of a patient with imperforate anus, and there's nothing there. It's like, well, I know where the midline should be because there's a crease on the backside where the butt cheeks come together. We know about where the midline is. So they're gonna have to go through and figure out how to create a new opening for an anus that was not naturally there. And then they've also gotta go into the belly and disconnect those connections between the end of the colon and the bowel, or the end of the colon and the vagina, or the bladder. Whatever those connections are, they've got to disconnect that to make sure that's cleared up. So as far as imperforate anus, I'm not going to go into step by step what it is. All the CST has ever asked is, what is Hirschsprung's disease? What procedure do they do for that? Well, they do the repair of imperforate anus. So know that surgery goes with Hirschsprung's disease. That's the repair of Hirschsprung's disease. So some of these, there are two names. You need to be able to connect those and remember to connect them. Know that females, it tends to be a little less invasive a surgery because they naturally have a vagina created. It's close to where you're trying to take it. With boys, it's higher up that they connect it to the bladder or the ureter, and so you may need to do a little more reconnecting and a little more movement to be able to repair that. What is next? Omphalocele or gastroschisis repair. So, that's a few pages further back under general surgery, abdominal procedures. So, gastroschisis and omphalocele, they put them together. It's two different repairs that look similar. Either way, it's disconcerting when you see a newborn that's got either one of these problems. And if you look at figure 2624 or 2625, it's obvious why that would be a little disconcerting when you deliver a newborn and that's what you find. So what's the basic problem? Are the guts inside the belly? No, they're not. We got a problem. So you don't have to be medically very trained to realize, oops, this is not right. How do we fix that? So surgically, what would you think you do if the baby's born and the belly is put together, but they've got an umbilicus and a belly button, and the guts have pushed out through that umbilicus? Are we gonna be able to get them anesthetized and then push all the guts back in there and sew it up? You would hope so, but the problem is they have been developing since very small size. As they've been developing, the guts have been outside and the belly wall didn't need to make room for all those guts. So you notice a healthy newborn kind of has a pooched out belly. They've got room for everything and it's full, but it fits in there. If the baby has developed in the womb with nothing in the belly and all of it hanging outside, it's developing out there, but the belly wall did not develop to make room for it. So what they do is on figure 2626, they sew a plastic bag into the belly wall around the umbilicus and it sticks out on the belly of the patient. And the guts go in the plastic bag and you put a red tie at the top. Seems a little odd, but it's what we've got. And every day the doctor will push from the top and advance the bread tie a little bit. So what you're doing is you're filling up the belly to the extent it will take it. And as it lays there stretched, a day or so later, you can stretch it a little more and push a little bit more of the gut in. And at some point you end up with all of the gut pushed in and you can remove the plastic bag and sew the umbilicus back together and you're back to a pretty normal baby again. But initially, the gut is born on the outside. So what's the difference between gastroschisis and omphalocele? You see that 2624? That one's an omphalocele. Where is the gut? It's outside the belly, but it's inside the umbilical cord, so it's protected somewhat. So the gut is a little more likely to be intact and in decent shape with omphalocele. With gastroschisis, it's broken through and there's not a seal or a bag of tissue protecting the gut. Also, if you look at the intestine of that child on 2625, does that intestine look healthy? Does not. So you're probably lacking blood supply to some of it. You're probably gonna have to remove some of it. And it is what it is. So the survival of the kids born with gastroschisis is not gonna be as high as the survival of the kids born with omphalocele, even though both are pretty shocking to see when that's your baby delivered and it's like, whoa, the cuts are on the outside, not cool. So both of them are impressive visually as far as defects. One of them is a lot less likely to lead to long-term health issues than the other. So the omphalocele it's not good news, but compared to the other option, it's better news. And so it's got the umbilical membrane covering the gut. That's what sets it apart from gastroschisis.
every single day, like back to surgery?
Well, the baby will be in NICU, in the
Oh,
neonate
so it's
ICU.
staying there, okay.
And so they're laying there in a warmer with a bag. And newborns don't flip around a lot, they lay wherever you put them. And so they are laid belly up, and that bag is there exposed, and every day the doctor will push a little bit more and advance that tie so that they're maintaining some belly pressure to stretch that wall. But the good news is, once you get to that point where you've got them bagged up, what you've got in the bag is healthy tissue, and so it's just a matter of time until you are able to stretch the belly and get it all back where it belongs and get it back where it should be. It does mention in the procedural considerations, and y'all probably have seen this for those of you that have been to Driscoll. Number one, what's the air temp like in the OR? It's hot. It's not just warm, it's hot. Why is that? Well, because babies have a lot of exposure compared to the body size compared to adults. They can't maintain being exposed to cold air as well. So we heat up the room. We also use warmers, and we're more conscious of warm blankets and things like that. And also, once we start, work fast and get this done and put that baby back under warm blankets and better conditions. So they're aware of that, but with this, you have to expose the belly. The gut is exposed. It's a lot of exposure. So it's probably gonna be an even warmer room for that surgery, because you're gonna have to keep the room at about body temperature. For the OR crew, what does that mean? It's miserably hot. That's what we do to fix the kid. So it is what it is. At Driscoll, do they have showers in the dressing room? I'm gonna guess they probably do, and they probably use them more than most hospitals, because you finish with this surgery, you're sweaty and wet, and you may need to go get a shower and dry off and get cleaned up, just because there's no way around it. It's going to be a hot procedure to keep the patient warm. Okay, Wilms tumor is several pages further back. And like I said, some of these surgeries that you'll see that we're skipping over, we've already covered in general surgery and other places. Some of them are uncommon enough, we're not gonna mess with them. Because do you remember, has anyone seen this book in the ORs around town? At the front desk, if you go look, there's some version of it out there. It is a reference all over the US for, okay, we got this weird thing on the board that my name is attached to. What the heck is that? Go look it up. So the weird ones, there are odd surgeries in here that we're not gonna touch. But once you become a tech or pay and you get assigned to a case with that, it's nice to be able to go look it up somewhere and have some idea of what it is you're doing. But if they're pretty uncommon, we're not gonna mess with them here, because you're not gonna be responsible for them at this point. But it's a reference book, so there's more in there than we're gonna touch. So with Wilms tumor, what it says in the book, it's general surgery resection of tumors. Wilms tumor is also known as nephroblastoma. So with the beginning of a word like nephro, what part of the body is this attached to? Kidneys. So nephroblastoma, it ends in oma. We know this is a tumor. And it's a malignant tumor originating in the kidney, and is most common intra-abdominal childhood tumor. Well, it's kind of sad, except are childhood intra-abdominal tumors common to begin with? They're a pretty odd occurrence. But among them, this is the most common one. So with Wilms tumor, what are the things we need to know? Well, at the end of that first section, it says nephroblastomas may cause hypertension, obstruction of the vena cava, obstruction of the hepatic veins, or the renal veins. So vena cava, hepatic veins, renal veins, what do those all share in common? They're they're all veins. And if you compare a vein and an artery, which one has lower blood pressure? The veins. And that's why this tumor is likely to obstruct the bigger veins around it, because they're under less pressure than the artery. The artery can still hold itself open. The vein's the first one you can pinch closed. So with Wilms tumor, we're worried about venous obstruction around the kidney. There are large veins. All three of these veins mentioned are large veins. They're critical. But that's what we're working on. So the first thing they've got to do is some testing to find out, is this tumor operable? Why might this tumor not be something we can operate on? Because it started in the kidney. Do tumors sometimes advance and grow out into new areas? Yeah. So if this tumor has advanced and grown into the liver, in around the heart, into the lungs, as a newborn, they may not be able to put up with this surgery at all. So it might be the doctor says, I'm sorry, we want to call the priest, we want to call whoever we need to. This is not going to end well for this baby. We can't fix this problem. So that's the first thing they got to do, is figure out, can we operate given the parameters of what's going on? So that's the first thing under operative procedure. If the tumor's operable, at the end of step 1, it says we would inspect the abdominal contents and clamp the vessel of the renal pedicle before we dissect the tumor. So we cut off the blood supply before we start poking around removing the tumor. Why would we do that? What do you know about tumors if you go poking around on them? Can the tumor cells break off? And they will go through the bloodstream somewhere else into the body. So if we go dicking around with the tumor, pardon my French, but if we go poking around on the tumor and we haven't sealed the blood supply, we might be moving the tumor around to other parts of the body to give them cancer somewhere else. And that's the last thing we want to do. So the whole do no harm, yeah, sometimes we have to make an incision. We're doing limited harm to do greater good, but the last thing we want to do is not clamp the vessels if we start messing around with the tumor, because that could very likely result in spreading the tumor. Step 2, all suspicious lymph nodes are removed. So if the lymph node is anything larger or harder than a normal soft little tiny bean of a lymph node, we isolate it, we cut it out, we remove it. Because what do lymph nodes do for the tissue around them? They filter out bad things. Whatever it is, the lymph node realizes this does not belong here, get it out. And initially store it in the lymph node. And if I can't eat it up with white blood cells and things like that, I'm going to work on breaking it down, and we'll get it out through the kidneys and remove it. But we will kill it first and work on removing it. So lymph nodes, if you get a cold and go to the doctor, where's one of the first places they poke around on your face? Under here, right? What are they looking for? Those are lymph nodes connected to the back of your throat that will be pulling out those bad germs and filled up, and they will be palpable. You will notice there's a hard lump there that hurts when I swallow, but that's an enlarged lymph node doing its job. It's removing and filtering out invaders. So the lymph nodes around the kidney will be doing that, or should be doing that. So we're going to look for any of those suspicious lymph nodes and remove them. Step 3, the surgeon explores the opposite kidney before dissecting the tumor. Why might they look at the other kidney? Because if it's also got a big tumor, part of removing the tumor is you remove the kidney. Can we remove both kidneys on a newborn?
No.
Can't do that. So if that is the answer, it's unfortunate, but let's minimize what we're doing to the patient as much as we can. So what makes sense is they go in first, isolate the blood supply, look for any lymph nodes that are odd, and get those out. Now, let's go look at the healthy side and make sure it's a healthy side before we're messing with the tumor. So they go look at the healthy side to be sure it is as it's supposed to be. And then on step 5, it says the abdominal cavity and viscera are thoroughly inspected for evidence of tumor extension or metastasis. So this tumor will grow, it will advance to other areas, and so they want to make sure, is it just localized to the kidney? If it is, we can remove that kidney and the associated structures with it, and hopefully can heal this patient. But if it's connected to a bunch of other parts, by the time we get to it, we may not be able to operate and do anything for it. The next one is sacrococcygeal teratoma. And I don't know about what they're teaching now, but when I took microbiology, I remember one of the terms that we looked at was terado. That was one of the medical terms that was in that class. And terado, anyone know what that means? Monster. So, have y'all ever seen in history books where a queen gave birth to a monster and so they got rid of it? It was a child with a birth defect. Why did royal children have a lot of birth defects?
Inbreeding.
Royalty can't just marry anybody. You gotta marry other royalty. And even if you go to the next country, that's your cousin. Well, if you keep marrying within the family bloodline, one of the issues is you're gonna have birth defects a lot more often. And so you'll run into that in history where the queen gave birth to a monster and the attendants got rid of it. And it's like, what does it mean she gave birth? Was that Chewbacca? What was that? What are they talking about? Well, they call it a monster tumor. There is an illustration on 26.31. 300 years ago, if someone gave birth to that, you call it a monster and you get rid of it. And I'm sorry, is that a baby? Yes, baby's got a problem. Did they know what to do with that? Was that baby gonna survive? No. But it's a human child. They just got a birth defect. And so a lot of people 300 years ago would take one look at that and go, oh, that's a monster, get rid of it. That's a baby. But yeah, they're not gonna survive. We can do what we can, but. So the sacrococcygeal teratoma is monster tumor, that's the name of it. Sacrococcygeal, what part of the body is this? The sacrum and the coccyx, it's the bottom part of the spine on the back between the hips, right? So it's a tumor that originates at the sacrum or the coccyx. That's where, figure 2631, that's where that tumor originates from, is the sacrum and coccyx. Is there anything we can do for that with modern science or modern medicine? Yeah, usually we can go through and correct that. But it says the second paragraph under resection of sacrococcygeal teratoma says an SCT is usually resectable but may undergo malignant changes if not removed early in life. This is one of those, if you have a child who is born with this, be glad you are in the USA. Because if you were born in Guatemala, by the time you make your way up to Driscoll, it may be too late to do anything with it. It really is a ticking issue that has a short life of operability on it. So at the end of that second paragraph, it says early surgical resection is important because these tumors are not sensitive to irradiation and are only temporarily responsive to chemotherapy. So if we're dealing with treating tumors, there's radiation, there's chemotherapy, what else is there? Well, did we mention radiation and chemo? Other than that, there's radiation and chemo, but not much else. You've got two ways to deal with it. One of them, from birth, won't respond, won't help. The other one, There's only a little window where it actually helps. So it's critical if the patient's gonna survive that they get early help. I guarantee if a baby's born in the US with anything near that, they're immediately going to the hospital to find out, what do we do for this, how do we fix this? So part of it is luck of where you're born in the world. Do you have access to decent care? And then the last little paragraph in the middle, it says resection is usually accomplished by removing or by placing the patient in a jackknife position and excising the tumor and pelvis. An abdominal incision may also be required. So it's a pretty extensive removal. Is this patient gonna be running marathons 10 years from now or 15 years from now? Probably not. But can they survive and live a productive life? Yes, if we get to it early. So that one, they don't go into detail on the operative procedure because it really depends. Is it this involved? Is it not nearly as involved? Is it worse? There's a wide variety of how do you deal with it when you get this. It really depends on how advanced it is. And so the answer is not one size fits all. What do we got next? Myelomeningocele and meningocele. So there's a lot of cases that you can flip through the pages of that. Some of them look familiar. We talked about them in the adult sections of those specialties. But on, if you're using the book on 1037, but it's the neurosurgical procedures. So on neurosurgical procedures, this one, if you look at figure 2639, does that look pretty devastating as far as birth defects go? Yes. If the spinal cord is open to the air, we're gonna have problems. How extensive will it be will depend on that particular situation. But so under myelomeningocele and meningocele, it mentions at the very beginning there, it occurs because of a congenital flaw in the neural tube closure at approximately 8 to 12 days after conception. How many moms even know they're pregnant 8 to 12 days after conception? You're not late yet, you haven't missed yet, you don't know. So this is a very early birth defect that takes place really early in development. They don't look like a baby yet, they look like a little letter C-shaped worm that's developing into something. So it's not even recognizable as a baby yet when this issue first shows up. It says the failure of the neural tube to close correctly causes a defect in the posterior elements of the lumbar vertebra, fascia, and dura, allowing the meninges, spinal cord, and nerve roots to protrude out in a sac or cyst through the skin. So the back part of the lumbar spine, the bones don't form. That's a problem. And also the spinal cord, the nerve roots are protruding out through the back of the newborn or the fetus beforehand with a sac. And it says there's always some degree of paralysis and loss of sensation below the defect. So does that mean they won't be able to walk or use their legs or go to the bathroom normally or any of that? It doesn't mean that. It may, but there's always some degree of paralysis below that defect. So they're not going to be running normally, they're not going to be able to move normally, but to what extent, it's an individual thing, it just depends. And then it mentions meningoceles are slightly different. They're similar, but not quite as neurologically devastating. The meninges and CSF protrude into a defect, but not in the spinal cord. So there is a defect sticking out on the back for both of them. One of them, the spinal cord and the CSF and meninges are protruding through, but not the spinal cord. Spinal cord is basically left in place where it's supposed to be. With the myelomeningocele, the spinal cord is also protruded out through the back in that sac. And so, is one worse than the other? Yes, but either way, there is some extent of paralysis involved. So it says under procedural considerations, these are all pretty generic, but something to know because I've seen them on the CST exam. First is that first sentence, infants born with either of these defects need to be given broad spectrum antibiotics immediately after birth and taken to the OR within 24 hours for closure of the defect. Close it up, because what's hanging out there in the breeze, that's the spinal cord. You cannot afford an infection directly into the spinal cord. So we want to go within 24 hours of birth to surgery and close it, but also have them on broad spectrum antibiotics to make sure that they do not get an infection directly into the central nervous system. And then at the bottom of that paragraph, it says a very high percentage of these children with this defect develop an allergy to latex. So you need to use non-latex gear when you work with these patients. So at Driscoll, I'm guessing most of their gloves are latex free, right? For those of you that have been. So they already go to that extent because young children are susceptible to developing allergies if you give them irritants. And glove powder is a very easy way to cause that. So now that, 20 years ago it wasn't the case. We didn't have many options of non-latex gloves. Kids just developed allergies. Now, if we have good gloves that are not latex, let's use that because it will minimize that chance of creating the problems with allergies. And then craniosynostosis, craniectomy or craniosynostosis. In neuro, this was covered a little bit, I believe. Have we done neuro yet?
Yes.
Yeah, okay. Believe it or not, classes run together, and at some point it's like, I don't remember if we talked about that or if the last class and I talked about that, but so with neuro, we talked a little bit about some of those, like the clover leaf expansions of the skull and how it can be misshapen if the fissures close, and they're not supposed to close yet. The skull is supposed to be kind of free floating as the child develops. So craniosynostosis is a premature fusion of one or more cranial sutures. It's simple when only one suture line is involved. It's compound if it's more than one suture line. And the purpose of the cranial sutures is to allow the calvera to bend during the childbirth process and to allow the skull to expand to accommodate normal brain growth during infancy. So, how many of y'all have seen a newborn that was born vaginally? If you've seen a newborn, you might have seen one that was born vaginally. So are those newborns the pretty babies? Or the C-sections the pretty babies?
C-section.
And we had them both ways. The C-section produces a pretty baby right out of the gate because they weren't squished and squeezed through a tube where they didn't fit through. But that's why babies are born with the non-connected skull plate, because they have to squeeze through a very tight passage. Do you have to spank those babies that are born vaginally, or are they born crying?
I don't know.
They're born very unhappy. They're like, look, I don't fit through a garden hose and you just squeezed me through one. I'm really upset here, this hurts. And mom's also kind of reflecting the same concept of, that hurts. So it's uncomfortable for that baby. Is there anything that makes sense that a baby that's brand new probably should cry for a little bit? How often have they breathed air before? Never. How do you make them do that? Because a C-section baby, what do they want to do? Sleep. It's like, you put me under that warmer and leave me alone, and now I'm taking a nap. Well, They didn't just get squeezed through a chute where they don't fit. So yeah, they're pretty, they're all perfect shape and everything else. The babies born vaginally, especially if they labored for a while to get them born, maybe kind of cone head, they may have black eyes, they look a little beat up because they're a little beat up. A week later, are they pretty babies? Absolutely. But immediately after birth, it's like, ooh, okay, that was rough. Welcome to the world, kids, it's gonna get better now. So for mom and for baby, that's a pretty rough process to go through. A week later, have any of you had a C-section? Was it easy to go a week later? You're still figuring things out, you're still healing. When you have a vaginal birth and you think, whoa, you're gonna drive that truck through this tunnel? I don't think so. Yeah, we are, and it's gonna happen. A week later, that mom is up and going. Say, wait, how in the heck do you recover from that? Because I saw that was traumatic. I don't know, we're just born, we're created to handle that. We're not created to handle a C-section. Thank goodness we have the ability to do C-sections, because sometimes there's a problem, and that's the way through. Our first, after 26 hours of pushing, the doctor finally was ready to punch this guy. He's like, Glenn, we gotta do something. We're gonna hurt somebody. I was like, thank you, don't kill my wife and my child too. Can we just cut him out? Because it was obvious the baby, every time she comes through, she twists and she's not coming through that way. Okay, between contractions, push it back, get her lined up right, but her head is twisted already to the wrong shape and she's not coming through the right way. So sometimes a C-section is the better answer. But with the craniosynostosis, babies when they're born, they're not supposed to have the brain fused together. It's supposed to be loosely put together. There are the two fontanelles, the little holes, the hollow spots. And anyone know how you can tell if a newborn is thirsty or dehydrated and needs to drink? It's a dent. So it's not just there's a soft spot, be careful when you're handling the baby. It's, hey, why is there a pothole on my baby's head? Well, they're thirsty. You need to feed the baby.
Damn, I didn't know.
So it's an easy indicator. You don't have to be a rocket scientist as a new mom. Hey, there's a dent and the baby's crying. What's going on? Well, and now milk's running out of me. Fix that. Look the baby in and let them handle that. So the system works well as designed, but sometimes babies are born and those bones fuse together too early. If you look at a newborn baby, what's abnormally large on babies? Just the way nature happens? The head, the eyes, right? So when we see any animal with a big head and big eyes, it's the same reaction. I don't know how you spell aw, but right? You see a kitten or a baby goat and it's got a big head and a little body and big eyes, and it's like, oh, look at that, that's cute. I want to pick that up and take it home. We have that reaction. With babies, it's not an accident that babies are born with a big head and big eyes, because you get that all reaction and everybody wants to take care of them. Is there another reason babies are born with a big head? The brain needs to be more developed than the rest of the body, because it's got to take care of driving the rest of that development. It's more advanced. The eyes are also more advanced, and can newborns see really well? They're kind of limited to right here next to you. Why is that? Because when I'm holding that baby, I want them to recognize my face. They already recognize my voice because they listened to me when I was riding on the inside. So they know the voice, but they start recognizing that face of who is mom, who's my caretaker, and they put that together. They don't need to be able to see things at a distance yet, and so they don't recognize that. But y'all have seen a lot of developmental books for little kids. There's a lot of black and white, there's a lot of black and red, there's a lot of patterns and things like that for them to start putting together as their vision improves. But for the skull, what we're looking at is this fusion that happens too soon. So when a baby's born, the brain is more developed than the rest of the body. Does that mean the brain doesn't grow from the time they're born? I hope it grows, because you need it to grow, but it won't grow as much as, say, your arms, your legs, your belly. The rest of your body will multiply in big parts how much it has grown. The brain, you can take the head of a newborn and double the size. That's about the size of an adult head. It is going to grow, but it's not going to grow to the extent that arms and legs and things like that do. So, surgery, what they're going to go do initially is carve a line in between the bones to allow them to kind of free float. You might see a kid who's in daycare or early elementary age who wears a football helmet or something similar to that. It's like, why is that kid wearing a football helmet? Leave that kid alone, he's got problems. Well, yeah, I know, but why is he wearing a football helmet? I'm not gonna make fun of him, but I'm just curious. People wanna know. Kids in elementary, I had a friend who his cousin showed up and he had a football helmet. I'm like, is he really that into football? Why does he wear a football? Oh no, he's got a problem with his head and the bones aren't connected on his skull. Okay, now I understand what they were doing with him. So they separate those bones and allow them to grow. And midway through the second paragraph there, it says surgery is generally performed on the infant between 6 weeks to 6 months of age, with the best cosmetic result coming from an earlier repair. They're going to separate those bones and allow them to free float. And at some point, either the bones will reconnect by themselves or they will go back and place bone fragments in between to allow a fusion to occur. And they can put a plate and screws and put that back together. I only saw one of these that was really impressive at Driscoll, and it was the cloverleaf look. And the kid had come from Venezuela, somewhere down south of Mexico, and it took them a while for the parents to work their way up to get to medical care. And so the kid, as the kid developed, I think the kid was 12, and it was the first time I saw a neurosurgeon bring in a 3D printed skull of the patient. I was like, oh, that's fancy. He goes, yeah, don't touch it. And he put it up there above the scrub sink. And I was like, yeah, no joke. Don't want to drop that. That's your model you're using to model your surgery after. And he scrubbed, and as I was walking away, he grabbed it and started to walk in, and he dropped it on the floor, and pieces went everywhere. And I was like, yeah, I'm out. I'm not coming back to that room. He's not going to be happy. But he still managed to fix it and get it going back, and they got it healed. But he said, yeah, basically, it would look better if we did this earlier. It would be simpler if we did this earlier. But she's grown, and her brain is expanding in this sealed case, and it's expanding where the joints don't expand, the bone plates expand. And so she had a lump on the top and a lump out each side, and kind of looked like a clover leaf from the front. And he said, yeah, what we're going to do is go in and cut the connections between those. He said, I'll cut in the middle of the plate and flatten it out. And we're going to let her heal, and we're going to leave 1/2-inch gaps in between the bones and let her grow. And when she's 16, 17, we're going to come back and we're going to fuse it all back together, because now her head is adult size and we can do that. So the initial concept of what they're doing is they're cutting loose the bone plates so that they're separate again and they can free float and grow with the child. And then once they get to adulthood, they can fuse it back together. It mentions DDH, or developmental dysplasia of the hip. I remember when I was, 5, 6 years old, I knew several kids around the neighborhood or just from church or wherever, just kids I ran across, who had hip dysplasia problems. And so what happens with this is, let's see, under repair of developmental dysplasia of the hip, about the third line down, it says, because the pathological process leading to hip dysplasia may not be present or identifiable at birth, It's essential to examine an infant's hips at each routine exam until the child is 1 year old. If you've had a baby and you took them to the doctor, one of the weird things that they did that you weren't sure why they were doing it was they would take the hips and bring the knees together, work them back and forth, work them through extension, flexion, all that stuff. And it's like, what are you doing playing with my kid's legs? They're looking at the development of the hips and how do they function. So if everything is normal, they don't even have to mention anything. Don't worry the parents. If you bring up potential problems, the parents will start finding that problem. But if you just go through it as part of what you're doing, you can talk and coo the baby while you're doing it. It doesn't hurt them, but you're putting them through range of motion tests, basically, to see are the hips developing correctly or do the hips dislocate on their own. So, to the middle of the second paragraph, it says, when correct alignment is disrupted, soft tissue and bony changes cause contractures of the hip muscles, a shallow acetabulum, and possibly a deformed femoral head. Well, the acetabulum and the femoral head is your hip joint, right? So if they are separating or dislocating, they're not riding where they're supposed to be, and that will cause the acetabulum to fill in, the hip may decrease in size, the femoral head. Changes can take place, and the soft tissue to connect them is stretched out, and it will grow stretched out. So they've got to figure out, what are we going to do to fix that? One of the things that they can do is they put a baby in a spica cast in 26.42. So that's not a from the waist down cast. What's obviously missing there? The whole midsection. Why? Because the baby's going to pee, the baby's going to poop. You've got to be able to clean them. But the outside and the tubes for the legs are intact to keep the hips from swaying out too far. So we can limit the hip movement, still allow you to clean the baby off as needed and keep them dry and allow them to develop. But they can go through that way. There may be times where they've got to go through and change the bony structure. They may have to clean out the acetabulum with a grater to be able to redevelop the correct connection there with the hip. But they don't go into much detail in the book because there's a wide variety of things they can do, and so they're not worried about, and CST is not worried about, what are the details on how they fix this? No. Know that hip dysplasia is a newborn issue with some, and that it's essential to find it early. They usually want to detect it before what age? 1 year. So if you've had a newborn that you took to the doctor just for a checkup, you can look back and think, oh yeah, I did see them playing with the legs back and forth and working them back and forth, outward, inward, all that. That's what they were doing, was checking to make sure the hip displacement or the hip dysplasia was not an issue, that they could function normally. With kids, as they're growing, a lot of these kids will be put into a brace that allows them to learn to start walking, but it keeps them from rotating the hips too far out. So a lot of passive things that they can do to help develop this without surgery. So frequently surgery is not something that is needed, but it may be. Let's see. And I think everything else that is in here is stuff that I think we've probably gone over. Did we cover cleft palate? Okay, so if you look over under the plastic and reconstructive surgery, the cleft palate repair is there. Y'all ever know anybody that had cleft palate? Or that maybe used to have it and you could still maybe tell a speech difference? We used to have a doctor who came from Central America somewhere, and when he was young, he had a cleft palate, and I don't know at what age they repaired it. But he only caught where it sounded like a cleft palate. And it's because the palate, the bony part of the palate where your tongue rests against the roof of your mouth, that's a hard palate. But if you run your tongue against the roof and go back, you can feel it gets softer and softer, and it's totally flexible back there in the back. That's a soft palate. A cleft palate is where the palate is divided. And you could stick your tongue up into the sinus spaces. Not supposed to be like that. Speech is going to be affected. What else would be affected? Imagine trying to eat food with a hole in the roof of your mouth. The food goes into your nose, and that's just part of eating. So it is a problem. Is it difficult to fix? No. If you ever volunteer for one of those, like a Mission of Mercy thing where they take a crew, a surgical crew, and go down to South America to some village and they fix problems, cleft palate is a very common thing that they run into that they can fix. So they'll start sending people down months ahead of time to say, go to this village, but also all the surrounding area, and tell them, if you find some kid with a cleft palate, talk to the parents and say, look, this is the date. Bring your kid over here and we'll fix it. And they can pretty quickly, it's day surgery, they can do it in the morning, send the kid home with instructions and say, please follow the directions, but your kid will now be able to talk, they'll be able to eat food normally, they'll be able to grow up and be a pretty normal person. It does leave a scar on the lip where you put it back together, but it will allow them, if you can catch this early before they try to learn to speak, their speech can develop normally. If they were 15 when they discovered the cleft palate and somebody fixed the palate for them, they've already learned to talk for 15 years in a different way, and that will always be the way they talk, unless they're really conscious about it. So cleft palate, cover that for a second. Otoplasty is one. So auto, what does it auto refer to? O-T-O. The ear. So otoplasty is surgical repair of the shape of the ear. Typically, it's a kid who looks more like this without fingers pushing their ears forward. When you go to middle school, is that a problem? Yes, the chickens are pecking on you all the time. I wish I could just pummel those kids sometimes and straighten them out, but kids are kids. They do that at that age. Why? I don't know. When I was that age, I was an idiot also, and I did the same stuff sometimes. Yeah. And then I had a kid whose ears stuck out a little bit, and they would get teased about it, and I'm like, look, God made you, you're perfect, you're fine. Can you hear okay? Yeah, according to my classmates, I could hear somebody sneeze in the next county. I'm like, yeah, I know, but. So, for those kids, is this something they need to be able to live a normal life? No. Do you know any adults whose ears stick out a little bit? Yeah, you can get by fine, it's fine. You're just slightly different shape. Just like shape of a nose, shape of an eye, whatever, breast shape. We're all a little different. But for patients who that really bothers, who want to get that fixed, they can go in and at the back of the ear, they peel the skin away and they can cut a sliver of the cartilage out and suture it back together, and it basically just pulls the ear back against the side of the head, brings it back into the normal profile. So for that kid, is it going to improve their hearing? No. The only thing it will improve is they don't hear insults as much because they don't look different. So that's the bottom line. It's purely plastic surgery to be able to change the shape of the ear. It covers repair of syndactyly. That one is a little more interesting. Have any of y'all ever seen a patient who had multiple fingers put together so that there was not a division between them? It was like these two are just stuck together. So it happens. It may not create that big of an issue in life, especially if it's the smaller ones, because you can still function. You got your thumb, that's the important one. All the others, if you've got some combination of them, you can make that work. But will people mess with you as you're growing up because your fingers are stuck together? yes, they will come up with ways to make fun of you. So kids are gonna want that fixed. They are more dexterous if all the fingers are separated. So the two things you need to know about syndactyly is, what is it? It's two or more fingers stuck together with continuous skin around them, so they don't have that gap. So know what it is, syndactyly, fingers stuck together, two or more. And then also know that if you look at that picture 26.49, does it look like there's extra skin there? You should be able to cut around it top and bottom, right? Separate them, sew the finger skin back together, and you're good to go. No. It looks like there's extra skin, there is never enough skin. You always have to have a skin graft. So if you're setting up for one of those, do you need to know a bunch of advanced things about surgery to help in that surgery? No, it's simple. It's plastics, get the same 5 instruments out that they always use, you're good. But you're gonna need a skin graft. That requires extra instruments. So just know that with syndactyly cases, you will need a skin graft, have that mesher and the dermatome and things like that available to be able to do that skin graft. I don't think, nope, everything else is congenital heart defects or birth defects that we'll deal with in the next chapter. So that's all we've got to cover in this one. Any questions on any of these? Well, I'm impressed from what Elda was talking about. It sounds like all of y'all are in pretty good shape. It's just after spring break and a lot of y'all are already meeting the minimums. So good for you. And it sounds like some of y'all are already